Good afternoon, everyone. I'm Caroline Hanley from the Workforce Development team at Murray PHN. I begin by acknowledging the traditional owners of the land on which we work and live. We recognise, celebrate and respect Aboriginal and Torres Strait Islander peoples as the first Australians. We acknowledge their unique cultural and spiritual relationships to the land and waters as we strive for healing, equality and safety in healthcare. We pay our respects to their elders past, present and emerging, and extend that respect to all First Nations people. I'd now like to introduce our presenter today, Narelle Williamson. Narelle is an asthma and respiratory educator and senior clinical consultant at the National Asthma Council Australia. Thanks for joining us today, Narelle.
Thanks, Caroline. Hi, everybody. So the topics that we're going to cover today are the Australian Asthma Handbook, paediatric asthma pathophysiology, triggers, diagnostic principles and management principles in children, written asthma action plans, acute medical management of children in primary care, and asthma and COVID-19 guidelines. So please feel free to type any questions into the chat box and make any comments along the way. I'm going to stop about halfway through and take any questions. So please feel free, no answer is too big or too small. The learning objectives are to identify the steps involved in the diagnosis of paediatric asthma, referring to the Australian Asthma Handbook. We'll describe the management of asthma across the different ages in children. We'll summarise the important information to be included in a written asthma action plan. And finally, we'll define the steps, in managing acute asthma in primary care. Just before we get started, this is our Australian Asthma Handbook. Our latest version was launched in September last year, so that's version 2.1, and this is available for everyone online. It used to be in paper or hardcover form, but it's only online now. It provides best practice evidence-based guidance for GPs, pharmacists and practice nurses. So I really encourage you, if you haven't seen that before, go to the site and have a look around. Every topic regarding paediatric asthma, adult asthma, springtime and thunderstorm asthma, allergic rhinitis, COPD, everything's in there. And this is the National Asthma Council website. This is where you can order resources. At the moment, we're not in the office every day. One of us generally goes in one day a week in order to bundle up any resources that you like, whether that be medication charts or brochures to hand to patients. So if you would like to order anything, please jump onto this website and order them online and we'll send them out to you. So some facts about children and asthma, and these statistics come from the Australian Bureau of Statistics National Health Survey in 2018, so released in 2019. Unfortunately, there's no further data since then, so I apologise for what appears to be dated facts, but it's all still relevant, of course. So asthma is one of the most common childhood conditions and the most common cause for presentation to primary care, emergency departments, and for admission to hospital. Research has shown that hospital visits due to asthma surge during the first month of the school year, and here in Australia, approximately 20 to 25% of children's hospital admissions of asthma occur in February. Asthma is more common in boys and girls aged 0 to 14 years, but it's more common in females aged 15 and over. Approximately 47% of patients hospitalised for asthma in 2018 were aged 0 to 14. Not all children with wheeze have asthma. 2 out of 3 children with recurrent wheeze aged 1 to 5 years don't have asthma at age 6. And 21% of children aged 1 to 12 who have asthma reported disturbed sleep over the previous 4 weeks. In 2018, asthma prevalence is twice as high among children with disability compared with children with no reported disability. So with disability was around 18%, no reported disability was 8.9%. And differences were also evident between children living in lower socioeconomic areas and compared to the highest, so 12% compared to 8.4%, and between children living in a one-parent family compared with children living in a two-parent family. So that's 13% compared with 9.4% respectively. So remember that asthma is a chronic lung disease which can be controlled, but it can't be cured. Asthma is defined by the presence of both of the following: excessive variation in lung function and variable respiratory symptoms. Asthma is an obstructive disease, and airflow obstruction is caused from excessive airway narrowing. And narrowing of the airway is due to inflammation of the lining of the airway and constriction of smooth muscles in the walls of the airway. There's also increased mucus production, and we can measure variation in lung function objectively with spirometry in children, we say around 6 years of age, but of course it is a very forced manoeuvre and a tiring manoeuvre to do spirometry. So we take the 6 years of age, you know, plus or minus. Some children can do it very well at 6, other children age 12 might not be able to complete a full spirometry. And of course, there's variable symptoms that can be reported by the child or of course by their parent or carer. So obviously it's important for us as primary healthcare professionals and the parents and carers to understand the pathophysiology and the changes to the airways in asthma. So here we have a normal airway, an asthmatic airway, and an airway during an exacerbation. So in the normal airway, we have nice, relaxed, smooth muscles in the walls of the airway, a nice hollow opening for oxygen to move in and out, and nice pink healthy tissue. The asthmatic airway, we can see the air in the alveoli starting to increase a little. There's a little bit of inflammation there, not as big an opening for oxygen, but the smooth muscles are still relatively relaxed. And in an exacerbation, a lot more air is trapped in the alveoli. You can see the tightening of the smooth muscles in the walls and a lot of inflammation where the wall is thickened and inflamed. So triggers for asthma in children, these can vary and symptoms are often delayed after exposure to the trigger. Common triggers are respiratory infections such as the common cold. That's probably the most common trigger. Exposure to cigarette smoke, e-cigarettes and water pipes. Weather conditions such as cold air or rapid temperature changes. Allergens, animals, pollens or mold or outdoor air pollution. And believe it or not, exercise and laughter, which is awful. We don't want laughter to be a trigger for asthma, but unfortunately it can be. So the Australian Asthma Handbook, the release before last year, so back in March 2019, that was version 2, that was a major release, and it saw a big overhaul of the paediatric asthma section and divided children into age groups 0 to 12 months, 1 to 5 years, 6 to 11 years, and then adolescents. So looking at children age 0 to 12 months, and these children experience a lot of wheezing, which isn't necessarily asthma. So wheezing in infants aged less than 12 months should not be treated as asthma. Wheezing in this age group is most commonly due to acute viral bronchiolitis or due to small or floppy airways. And advice should be obtained from a paediatric respiratory physician or paediatrician before administering short-acting beta-2 agonists, systemic corticosteroids or inhaled corticosteroids under 12 months of age. So in the 2019 updated handbook, in the major update, there are no recommendations for specific asthma management in children under 12 months due to the emphasis on the low probability of asthma. There is a section on wheeze in infancy, updated for consistency with national guidelines for management of bronchiolitis. So you're more than welcome to have a look at that. Looking at diagnosis of children 1 to 5 years of age, and this is a really large group and it can be confusing, a confusing and tricky age group, and therefore asthma diagnosis can be difficult. And this is because episodic respiratory symptoms such as the wheezing, but also cough, are very common in children, particularly in children under 3 years of age. Objective lung function testing via spirometry is usually not feasible in this age group. And a high proportion of children who respond to bronchodilator treatment do not go on to have asthma in later childhood, for example, by primary school age. Many infants and preschoolers have wheeze when they have viral respiratory infections, and if we can, it's preferable to confirm that the breathing sounds described by parents or carers as wheezing are actually wheeze. So if possible, I know it's not always possible, but it would be great to see the child during a bout of wheezing. And because this isn't always possible, you can ask parents or carers to make an audio or a video recording of noisy breathing, for example, on their phone. And then you can show parents or carers a video of true wheezing and ask them whether signs match that with their child. So, diagnosis in children 1 to 5 years is based on history, and this includes any family history of asthma, personal history of eczema or allergic rhinitis, maternal smoking during pregnancy, previous wheezing episodes or noisy breathing, and the frequency and timing of previous episodes. Of course, then we would conduct a physical examination. We would observe for signs of rhinitis, including the frequent up-rubbing of the nose or the possibility of a nasal crease. Observe breathing, auscultate for wheeze, remembering that wheeze is suggestive but not diagnostic of asthma. Look at the shape of the chest and observe their work of breathing and possible tracheal tug. They may have use of accessory muscles if the child is having an asthma exacerbation at the time of your consultation. And a treatment trial can also be useful in diagnosis. Reported noisy breathing that responds to bronchodilator therapy is likely to be genuine wheeze and to be caused at least in part by constriction of airway smooth muscle. Children 1 to 5 years of age and their management. Drug delivery is very variable in young children with any type of inhaler. So we need to manage symptoms with as-needed reliever therapy during wheezing episodes in those children that have been shown to be salbutamol responsive in a treatment trial. A metered dose inhaler with spacer, with or without a mask, remain the recommended first-line choice, and children less than 5 years should be discouraged from using a metered dose inhaler alone or breath-actuated devices or dry powder devices. A small proportion of children may need a regular preventer for symptoms that occur at least 4 to 6 weekly, and they may disrupt the child's sleep or play. Otherwise, a low-dose inhaled corticosteroid should be considered as the first choice preventer for those with symptoms that are frequent, for example, if they have daytime or nighttime symptoms at least once a week, symptoms that restrict activity or sleep, or a history of flare-ups, for example, if they've required treatment in the emergency department or required a hospital admission. Montelukast, such as Singulair, might be considered as an alternative to an inhaled corticosteroid when any of the following apply. So if the child is unable or refuses to use an MDI and a spacer and mask, or if the child has significant allergic rhinitis that requires treatment, or if parents, despite your education about risks and benefits, decline inhaled corticosteroids or are significantly concerned about their adverse effects. And poor adherence is likely in this context. So this group of children rarely require a combination medication of an inhaled corticosteroid and a long-acting beta agonist, but it's extremely important to provide parents and carers with a written asthma action plan. Looking at 6 years and over now, diagnosis for that group. And the diagnosis of asthma can be made with more certainty in this age, as they're school-age children. Diagnosis is based again on history, so family history of asthma, personal history of eczema or allergic rhinitis, maternal smoking during pregnancy, previous wheezing episodes, noisy breathing, frequency and timing of previous episodes. Then the physical examination again, observing for signs of rhinitis, observe their breathing, auscultate for wheeze, look at the shape of the chest, and they can also have a treatment trial, so that response to inhaled bronchodilator. And in this age group, diagnosis can be supported by diagnostic testing and the presence of reversible expiratory airflow limitation on spirometry. Again, different for each child. Some children will be able to complete spirometry, some won't. So provisional diagnosis of asthma can be made if the child has all of the following: wheezing accompanied by breathing difficulty or cough, Other features that increase the probability of asthma, such as a history of allergic rhinitis, atopic dermatitis, or a strong family history of asthma and allergies. If they have no signs that suggest an alternative diagnosis, and it's clinically important that they have a response to bronchodilator demonstrated on spirometry if, again, the child is able to perform it. Again, as mentioned earlier, reported noisy breathing that responds to bronchodilator therapy is likely to be genuine wheeze and to be caused, at least in part, by constriction of airway smooth muscle. So as mentioned, in this age group 6 years and over, the presence of reversible expiratory airflow limitation on spirometry definitely supports the diagnosis of asthma. Classification is based on the clinical pattern of symptoms when not taking a preventer and also when the child is well. For example, they don't have a respiratory tract infection. All school-age children with asthma need a reliever medication, and it's usually Ventolin, to use when they experience asthma symptoms or an asthma exacerbation. And the guidelines in the handbook indicate that regular preventer treatment is indicated for those symptoms that occur at least 4 to 6 weekly and disrupt the child's sleep or play. First line preventer for this age group is low dose inhaled corticosteroids, and we always aim for the lowest dose to achieve good control. The dose is determined by risk and by the severity of flare-ups. And we need to review the child regularly to assess asthma control. If asthma is not well controlled by regular low-dose inhaled corticosteroid treatment and their adherence is good, their inhaler technique is correct and diagnosis have been confirmed, treatment may need to be stepped up. So we can consider one of the following options. We could consider increasing the inhaled corticosteroid dose. We could continue low-dose inhaled corticosteroids and add montelukast if that is preferred by you as health professionals and the parents. So that's a once daily chewable tablet. Or you could switch to an inhaled corticosteroid long-acting beta agonist at a very low dose. So that would be Seretide or Symbicort. There's also an option of tiotropium over 6 years with moderate to severe asthma. So that would be a Spiriva Respimat or a Braltus Sonda, but that would be prescribed by a respiratory specialist. So this slide just demonstrates what I've gone through, and it's the stepped approach to selecting and adjusting asthma medications in the children aged 6 to 11 years. And it outlines asthma treatment levels 1 down the bottom through to 4 up the top, according to the intensity of the medication needed to control symptoms and prevent exacerbations. So it's the number of medications, the type of medication, and the dose of the medications. Once again, the aim is to monitor and adjust medications at each review with the GP to maintain good asthma control on the lowest effective medication dose. So asthma control in children, similarly to adults, but the criteria are different, but it's categorised as good, partial or poor control. So it is based on symptoms over the previous 4 weeks, and it involves looking at daytime symptoms of wheezing, cough or breathing problems. If there's any limitation of activities when the child is fully active, running and playing. It's also based on nighttime symptoms, such as is there any cough during sleep or waking with symptoms of wheezing. Also the need for SABA or reliever medication, but that does not include doses taken prophylactically before exercise. That needs to be recorded separately and taken into account when assessing management. And each child's risk factors for future asthma outcomes should also be assessed and taken into account in management. So a child who is well controlled, they should have all of the following: daytime symptoms 2 or less days a week, no limitation of their activities, no symptoms during the night or when waking up, and they only need their reliever less than 2, hopefully not even that much, but less than 2 days a week. If they're only partially controlled, they might have any of the following. They might have daytime symptoms greater than 2 days a week. They may have some limitation of activities, any symptoms during night or when wakes up, and the need for reliever medication more than 2 days a week. And with poor control, it's either of the following. So daytime symptoms more than 2 days a week and greater than 3 features of partial control within the same week. So you're looking back to the partial control criteria there. So reasons for poor asthma control. Well, poor asthma control in children is usually around parents stopping or decreasing the child's medication, the preventer medication. After preventer medication is started, the child's symptoms improve, and that's what we would expect. But then the parent stops the medication before they're reviewed. Parents require, therefore, good knowledge of asthma and its management. And this should, of course, be a GP's decision whether to stop or continue any medication. There also could be uncontrolled allergic rhinitis or allergen trigger exposure, which results in poor asthma control. The child may not have a written asthma action plan, nor having regular asthma reviews with their GP. Or, of course, it could be a diagnostic issue where it's actually not asthma at all. We won't go through all of this slide, but it's just to reference the alternative diagnoses and the importance of investigating as required. So not everything that wheezes is asthma. For instance, let's choose a couple. So just down the left-hand side, crepitations on chest auscultation that do not clear on coughing, for instance. That suggests a serious lower respiratory tract condition such as pneumonia, atelectasis or bronchiectasis, or unilateral wheeze. That usually suggests an inhaled foreign body. So they're just other alternatives to a diagnosis of asthma that can be found in the asthma handbook. So as a general guide, when we review each child's asthma, we need to review every 3 to 6 months when their asthma is stable and well controlled, which I know probably seems a lot, but if they're well controlled, it needs to be 3 to 6 months, 6 months at the maximum. We also need to review children 4 weeks after increasing any dose or any number of medications to regain control of partially or poorly controlled asthma. And we would also want to review them 4 to 6 weeks after decreasing a medication or stepping down treatment. More frequent follow-up is required for children with any of the risk factors such as a confirmed food allergy, poor asthma control, maybe they've been admitted to hospital in the preceding 12 months, maybe they've had a history of intubation for acute asthma, there may be overuse of short-acting beta agonists or reliever medications, there may be frequent failure to attend consultations, there may be abnormal spirometry findings, poor adherence to preventer, poor inhaler technique for preventer, poor adherence to asthma action plans, significant parental socioeconomic problems. They may have had exposure to tobacco smoke, exposure to clinically relevant allergens. So any of those risk factors, we would need to be providing more frequent follow-up for any of those children. And then if a child is admitted to hospital, after a hospital presentation, the guidelines recommend to arrange a follow-up with the GP within 3 days of discharge, and then a more comprehensive assessment in 2 to 4 weeks to review the treatment regime. And validated questionnaires can be used for assessing recent symptom control, and there's the TRAC and the C-ACT for children, which you can find both of those in the asthma handbook under clinical and under post-acute care. So they're really good questionnaires to use if a child has had an admission to hospital. So at each asthma review, we want to assess asthma symptom control based on reported symptoms, if there's any limitation of daily activity, and also on the child's need for reliever medication. We need to assess if the child has any risk factors for future adverse events, for example, previous severe life-threatening hospital admissions, a history of sudden, severe, unpredictable asthma flare-ups. And of course, we want to try to identify what triggers asthma symptoms. Is it allergens? Is it cigarette smoke? Manage those comorbid conditions that affect asthma, such as allergic rhinitis or eczema. Perform spirometry as required in those children old enough to satisfactorily perform the test. And we need to provide parents and carers and children who are old enough to understand with information and skills to manage their asthma. Show parents and children, if they're old enough, when and how to take reliever medications and how to use a spacer. And you can give them brochures, you can direct them to the how-to videos on the National Asthma Council website to support maximising their adherence to their medications. Ensure there is a written asthma action plan and that it is up to date. Provide advice about avoidance of tobacco smoke, healthy eating, physical activity, healthy weight and immunisation, and ask parents or the child if they have any concerns about their treatment. I can't stress highly enough that regular review using the stepped approach to maintain good control of symptoms and prevent flare-ups while minimising the dose of inhaled corticosteroids is key. And we can also identify future risks such as poor asthma outcomes in the future, which may be due to overuse of short-acting reliever medications, severe asthma, poor adherence, history of sudden severe unpredictable flare-ups, or significant psychosocial factors, just for some examples. Okay, well, this is our new medication chart. It was released in November last year, and whilst I say new, we're reviewing it again and releasing a new one probably in 2 months. We're just trying to find some room to put another couple of medications. As you can see, it's pretty jam-packed there. But the good thing with this medication chart and with all future medication charts is down in the left-hand corner is the QR code, which is a direct link to the NAC's how-to device videos. So you can order these through the National Asthma Council website. We can send them out to you. They come in A3 size for your clinical treatment rooms or GP consulting rooms. And they also come in a handy A4 size, and they're really great to hand to parents. And they can then scan the QR code, which takes them straight to the videos. I'm recording a few more in the next couple of weeks, but every device that you see there has a how-to video. These charts are also helpful for when parents can't remember the names of their child's medications. We can use these in our consults with them to get to point to the ones they use, although in most cases they should be bringing the medications in with them. But it also highlights if they're using 2 medications from the one group. But yes, just keep an eye out for the new medication chart. It will be probably November again that it's released. This table identifies low and high daily inhaled corticosteroid doses in children. So these doses are equivalent for QVAR, which is a TGA-registered CFC-free formulation, not overly popular out there on the market. A QVAR is only available for children over 5 years. And then we have budesonide, which of course is Pulmicort and Symbicort. A low dose is 200 to 400 micrograms. A high dose is 400 up to 800 micrograms. And budesonide in those 2 forms of Pulmicort and Symbicort is PBS listed for children over 4 years of age. But Symbicort we generally don't prescribe for over 12 years of age. That's a combination medication of the inhaled corticosteroid and the long-acting beta agonist. So then we have cyclesonide in Alvesco. It's becoming a bit more popular on the market. So a low dose is 80 to 160 micrograms. And a high dose is 160 up to 320 micrograms. Alvesco is available for children over 6. Then we have fluticasone propionate. That's listed on PBS for over 4 years of age. And of course, we've got our flixitydes, which are the most common inhaled corticosteroid on the market. And then we have fluticasone cipla, Axetide, Cell Plus F, Seretide, of course, which is another combination medication. And that is available over 4 years. And then we have our fluticasone furoate, Nuity ellipta, which I haven't seen many children on, but nevertheless, it's still there. For 5 to 12 years, it's 50 micrograms daily. Over 12 years, it's 100 to 200 micrograms daily. But Alvesco and Pulmicort can be prescribed daily or BD, depending on the dose required to maintain good asthma control. And it's important to remember that 2 puffs of one medication does not necessarily equal 2 puffs of another medication. So if we're changing children's medications around, just because they're on 2 puffs of Flixitide may not necessarily mean they have 2 puffs of Seretide, etc., etc. And this slide's adapted from the Asthma Handbook. As the heading says, it's devices for young children, and it's, as I've already said, but I can't stress enough, always check device use at every opportunity. Support children to self-administer when they're able to. For children, a metered dose inhaler and spacer is the preferred device. Masks can be used for smaller children. As you can see, they can be used right up to 4 years. It's always important too to remind parents and children to shake the MDI in between each puff into the spacer. So you shake the MDI, do 1 puff into the spacer, then they should be taking 4 breaths per dose. A lot of parents, and it's understandable, they've not been educated, but they will just press 1 actuation of a Ventolin, for instance, into a spacer. The child will breathe in and out, then they'll just press the Ventolin again, couple of breaths, press the Ventolin again, couple of breaths, press the Ventolin again. And because they haven't shaken the Ventolin in between, that child's only getting maybe 1.5 doses. So really important to educate them to shake that metered dose inhaler in between. If they're not using a spacer, similarly, they still need to shake the MDI in between, but generally children can't get enough of the medication down into their lower airways where it's needed the most without using a spacer. No one can, even adults, so a spacer is always recommended. And there's amazing spacers out there on the market now. We don't have to all carry around those huge football-sized or football-shaped volumatic spacers. There's Breathatex. There are La Petite E-chambers, which are smaller than Breathatex, and Ventolin actually fits into it, which is handy. And then there's also spacers called Light Airs, and they are a rectangular collapsible cardboard spacer. They can't be used for as long as Breathatex, but they're very handy just to pop into the school bag, pop into the car glove box. It's better than nothing. So looking at our written asthma action plans now, remember that asthma is frightening for both the child and the parent or carer, and severe or life-threatening asthma attacks are more likely to occur in all patients with inadequate medical supervision. So an individualised written asthma action plan should be developed so that a child with asthma or their parent or carer can recognise deterioration of symptoms and respond appropriately. So action plans are based on symptoms and or peak flow measurements. And if we're basing them on peak flow measurements, they must be based on the child's best result when they're well. Using their own peak flow meter, we usually record morning and evening values for at least 2 weeks. So written asthma action plans improve outcomes. We find that children miss school less often and don't miss their sport. They wake less at night and they have improved symptom scores. So action plans recognise worsening asthma, including increased symptoms such as wheeze, cough and breathlessness, especially waking from sleep. And they give advice for adjusting medication, advice when to see the doctor and when to call an ambulance if necessary. And we would hope that that doesn't have to happen too much if you're in possession of a written asthma action plan. But all children with asthma, all children need to have a current written asthma action plan. And the good thing is these days that childcare, kindergartens and schools all ask for the updated action plan generally at the start of the year. So it really just preempts adult parents going to the GP to get an updated plan. And it certainly makes me feel better to know that really you can't enrol in school for the next year unless you provide your asthma action plan. So many times we'd receive clues that an asthma episode may be developing before breathing difficulty begins. And these clues are called early warning signs, and they are often unique for each child. Keep track of these signs for a few weeks. It's helpful for parents to look back on past episodes and see if their child had any early warning signs. And common early warning signs might include dark circles under the eyes, increased pallor, a stuffy nose, a runny nose, maybe a lot of sneezing, or it could be an eczema flare-up. Their child might be more tired than usual, they could be more irritable than usual, and they may be having trouble sleeping. They may report that they've got a headache. They may be breathless or coughing, on exertion, general coughing and wheezing. So it's really important to look out for those. Symptoms of acute asthma in children can also differ from child to child. Some may have shortness of breath, which may present as rapid, shallow breathing. Some may have wheeze. Some may have cough, again, particularly at night or in the morning or with exercise or excitement. Some will use their accessory muscles. They may have tracheal tug, rib retraction, or be using their abdominal muscles in breathing. They may have pallor and, again, irritability and lethargy due to that increased work of breathing. So management of asthma in general practice, what do we do? Firstly, we're going to do a primary assessment. So we assess the severity of the acute asthma episode, and we do that preferably with the child in a sitting position. We would look at their pulse oximetry and see what that's at. Is it mild, moderate? Is the child breathing? We would like the child actually to be breathing air if possible when you're doing the SATs. Excuse me, unless it's life-threatening, of course, but preferable before oxygen is being administered. We would be administering bronchodilator. We would then perform a secondary assessment, managing all of this time and then following up. So this table features more than one, well, it's 3 categories, but if more than one severity of category are present, we record the higher category as the overall severity. So if someone's experiencing one component of life-threatening and only one component of severe, we would deem it a life-threatening episode. So let's have a quick look. So mild to moderate, children can generally walk around or they're running around and playing as they generally do, speaking whole sentences in one breath, and oxygen sats are generally greater than 94%. If they're in a severe exacerbation, they would be using those accessory muscles or subcostal recession, tracheal tug. They'd be unable to complete sentences in one breath. They'd be in obvious respiratory distress, and oxygen sats may be between 90 to 94%. And if it's life-threatening, it could be any of those symptoms there. So reduced consciousness or collapse, exhaustion, cyanosis, poor respiratory effort, or it may be absent breath sounds, and their sats are generally less than 90%. So as I said, if there's one criteria out of those 3 that's in the higher category, perhaps life-threatening, yet they can, let's say they're cyanosed, but they can still walk into the clinic, or their sats are less than 90, but they're still able to complete sentences, we would classify it in the higher category. So mild to moderate exacerbations are the most common presentations to GPs. So if we're looking at mild to moderate management, we would usually be giving salbutamol 100 micrograms via a spacer using an MDI. So for children 1 to 5 years, that'd be 2 to 6 puffs. And in children 6 years and older, it'd be 4 to 12 puffs. We'd repeat those doses every 20 to 30 minutes for the first hour, or sooner if necessary. So again, that's 1 puff at a time, followed by 4 breaths, remembering to shake the MDI in between the actuations. We want to monitor and maintain oxygen saturations of at least 95%, administer oxygen therapy if oxygen sats are less than 95, complete observations and assessments when appropriate, based of course on clinical priorities, observe the child for at least 3 hours or until increased work of breathing has resolved. If there isn't a response to treatment, we would be calling 000, and we would repeatedly be reassessing response to treatment and either continuing treatment or adding on treatments until the acute asthma exacerbation has resolved or the patient's been transferred to ED or hospital via an ambulance. We can use nebulized salbutamol only if the child is unable to breathe through the spacer. We can consider commencement of oral corticosteroids within the first hour of treatment also, so that would be your ready pred. Emergency management of life-threatening episode, and I hope this never occurs for you guys because it's not nice. But this is what we would do. We would administer oxygen-driven salbutamol via continuous nebulization. So if a child is between 1 to 5 years of age, we would be giving them 2.5 milligram nebules. If they were over 6 or 6 or over, it would be 2 5 milligram nebules of salbutamol. We'd monitor and maintain oxygen sats at least 95% or higher, arrange immediate transfer to the emergency department. If they're having a poor response to salbutamol, we could add Atrovent, nebulized Atrovent or ipratropium bromide. If there's no improvement or worsening, we can add IV magnesium sulfate. So when using a nebulizer, the volume should be 4 mL of fluid. So that's either 2 nebules or 1 nebule and saline, and the oxygen is being delivered at 8 litres per minute, not via air compressing pumps, but generally in primary care, we have oxygen cylinders anyway. Looking at the Atrovent doses, if a child is 1 to 5 years, it should be 250 micrograms, or older than 6 years, it should be 500 micrograms. So when the dyspnea improves, we should consider changing to Ventolin via the meter dose inhaler plus spacer, or an intermittent nebulizer every 20 minutes. And these are just the charts. I've just summarised those ridiculously busy charts for you, but they are available on the Australian Asthma Handbook website under acute asthma. So you can find those there if you wanted to print those out or have us send them to you to have up in your treatment rooms. Following up with a child after an acute flare-up, we would initially review them with the respiratory nurse or nurse practitioner or GP in 2 to 3 days, and then that comprehensive assessment within 2 weeks. Review that particular flare-up or attack, try to identify what triggers were involved and associated with that acute flare-up, review medication, check preventer use and technique, check adherence, did they have a reliever available at the time, provide the follow-up written asthma action plan because the written asthma action plan will definitely change, review self-management and action plan use, use spirometry to monitor lung function if it's appropriate, and it's definitely not appropriate within the first 1 or 2 weeks because the lung function of a child is just not back to 100%. So you wouldn't be doing spirometry in the first couple of weeks, but maybe 4 weeks after an acute flare-up if they can perform spirometry. And as I've already mentioned, review and modify the treatment plan. So this is the community first aid protocol, also known as the 4x4x4. I'm sure you all have these charts, or you all would know the 4x4x4. So we give 4 separate puffs of SABA, which is usually Ventolin via a spacer, 4 breaths per puff, wait 4 minutes, and if symptoms persist, repeat those steps. If there's still no improvement, call 000 and continue those steps until help arrives. And of course, we would always stay with the child. We'd have them sitting up if possible. We'd be trying to calm and reassure them. And we are usually administering the medication for them, of course. So these charts are available on the NAC website also, and they also are being updated. So watch out for the new versions of those. Just a little bit now about asthma and COVID. Again, I keep repeating myself, I feel, but check everyone with asthma has a current written asthma action plan and utilise telehealth if need be. I know not everyone's keen to go into a medical clinic at the moment for fear that there's going to be COVID exposure, but telehealth is amazing for reviewing current written asthma action plans. If you have video access, that's great to perform too. And you can also check device technique, obviously, if you have video conferencing. If performing spirometry, follow the latest TSA and Z recommendations. Well, in New South Wales and Victoria, we shouldn't be performing spirometry at all. If there's any community transmission of COVID-19, spirometry should not be performed, so it's irrelevant for New South Wales and Victoria at the moment. If you were, more so with adults really, but if they were requiring lung function testing for diagnostic reasons, you'd be sending them off to a hospital to a respiratory function lab. But I have written infection control recommendations and they're on our websites. Under COVID-19, you'll be able to scroll down and find them for the time when we can all commence spirometry again. But it's always important to adhere to the guidance of our states. Other aspects with asthma and COVID-19, we would advise to continue with current asthma medications, including inhaled corticosteroids. Only use oral steroids for severe flare-ups. Avoid using a nebulizer. A well-fitting mask and spacer with puffer is definitely preferred. And we would tell parents not to share any medications or spacers, even between family members. Advise them to, everywhere they go, to have their medications handy, especially their reliever therapies, as would be outlined in their action plan, and also to know where the nearest COVID clinic is. So we're getting towards the end now, and these are just a few resources. I've mentioned the Asthma Handbook at that link there for all of our current Australian asthma guidelines. There'll be another small update to the handbook in November this year, and then our major update, I think around the middle of next year, we're aiming to have that put out. Our National Asthma Council website for all of the brochures or charts that are free for you to order. Our how-to videos, which are very, very useful for parents, especially to watch and just reiterate use of devices. Then there's our sensitive choice program that anything, you can see the blue butterfly up there in the corner, any products, anything from pillows, mattresses, vacuum cleaners, anything with the blue butterfly, you know it's recommended by sensitive choice. So little or fewer chance of children having any mattresses or pillows with that would increase their chance of allergies, basically, is what I'm trying to say. And then our social media, Twitter handle, Facebook handle, and then just acknowledgements of the few of us who wrote this webinar. Thanks, Caroline. That's the end for me.
Fantastic. Thanks so much, Narelle. We do have a couple of questions. The first one is, how do you know if a Ventolin puffer is empty?
Oh, that's a great question. Usually you can float it in water. And I know if there is medication left in it, you don't want to float it in water, definitely. But the majority, with other medications, it's a bit tricky. But generally with Ventolin, you can't feel, when you shake it close to your ear, you won't hear anything moving around inside. So Flixitide, Ventolin, any of the MDIs, they're a lot easier to tell. And they actually, these days, Ventolin and Flixitide come with a dose counter, which is awesome because they once upon a time didn't. It's only this year that they've come out with a dose counter. If you happen to have a Ventolin that doesn't have a dose counter, just by shaking it, you'll be able to tell, but pop it into water and it'll float if it's empty.
Narelle. And just to recap, how do attendees request a copy of the fantastic medication chart once it's been updated?
Yeah, so if you go onto our website, if anyone wants to write this down, I'll just duck back. So www.nationalasthma.org.au, and under there'll be a tab called Resources. Go to the resources, and I think from memory it says Order Resources or Online Resources, and it's very easy to find. You'll be able to find it there. And I think we allow 20 to be sent out at a time, but we've just got a huge new batch. Having said that though, with our new chart coming out, I could send you perhaps the 20, and then when the new one comes, I can immediately send out to whoever it is that's requesting them our new updated chart. So the National Asthma Council website is where to go. It might say clinical resources. I just can't remember off the top of my head, sorry. But you'll find it, no problem.
Fantastic, thanks very much. Before we conclude today, and we've just got a thank you there from one of the attendees. Thank you, Narelle. Before we conclude today, I'd just like to share some additional resources which are available on Murray Health Pathways. So if you don't already have a login, you can request access via the website displayed on the screen. Health Pathways is a free web-based portal and it's available for use by clinicians at the point of care to access evidence-based locally accessible patient pathways. In the Murray PHN region, we have 650 or more than 650 pathways which have been localised for our area, and that's with input from more than 100 health professionals. So just to highlight that the information provided in today's webinar is for information purposes only, and it does not take into account individual circumstances. Practitioners will need to make their own professional judgment on a case-by-case basis. So in addition to the National Asthma Council survey, so that is displayed on the screen, and if you would like to scan that with your phone, the QR code with your phone, that will take you through to a webinar evaluation for the National Asthma Council. So for upcoming webinars, please check the Murray PHN website, and if you haven't already, you may like to subscribe to our new events update. So thank you once again, Narelle, for joining us today, for your presentation and for your time in preparing. Thank you everyone for joining at the end of your day, and I hope you enjoy the rest of your evenings. Thank you, Narelle.
Thanks, Caroline. Thanks for hosting. Bye, everyone. Take care.
Bye.